Right. Good afternoon, and welcome to the webinar Fostering Social Support to Improve Clinician Resilience. My name is Sarah Gudema, Project Coordinator and Specialist at the Association of Clinicians for the Underserved, and I will be your moderator today. This webinar is brought to you by the National Health Service Corps Empowering Clinicians for Resiliency and Transformative Care Initiative, a project of the Health Resources and Services Administration. Diane Thabby King, who is the Senior Public Health Advisor in the Division of National Health Service Corps from HRSA, typically provides our introductions. Fortunately, she was unable to do that today, but she wants you to know that she is excited that you all will have this opportunity to engage and eager to hear your thoughts. We're so excited to continue talking to you all about the ways that you can foster organizational resilience and support clinician well-being. This initiative was designed to help National Health Service Corps participants and new clinicians in the field prepare for the rewarding and challenging experience of serving in health professional shortage areas. We're so grateful for those of you who have been able to attend our webinars and take advantage of our resources. As part of this initiative, we've also designed resources targeted at leadership and administrative staff at National Health Service Corps approved sites. You are all uniquely positioned to positively influence the culture, work environment, and organizational policies and practices that can lead to improved clinician wellness. We're really glad to see that so many of you have been joining our webinars to learn more about how to support your clinicians. We can't do this important work without you. For those of you who may have missed webinar series 1, Clinician Wellbeing and Self-Care, you can find those webinar recordings on our archived resources page, which we'll post the link to in the chat now. The webinar recordings from previous webinars for webinar series 2, Fostering Resilience at the Organizational Level, can be found at our webinar registration page, which we'll also post a link to. Today, we'll be diving into the topic of social support. Social support is a broad term encompassing the many possible ways that you can receive help through your connections in your community. It can take many forms, including emotional support, like receiving positive affirmations from a peer, as well as instrumental help, like receiving direct guidance or access to resources from a coworker. Social support is linked to improvements in psychological well-being as it supports individuals' adoption of healthy behaviors, self-esteem, and use of active coping strategies. In the workplace, social support can improve team communications and reduce stress, placing clinicians in a better position to provide the care patients need. Everyone's social support network will look a bit different. What works for you might not work for someone, and vice versa. Today, we'll go over a range of strategies that will help you strengthen your social support network in and out of the workplace. This will include organizational strategies to foster communication and relationship building among clinicians and other staff, as well as personal strategies you can use in your day-to-day life. We hope you leave this presentation equipped to build a strong personal social support system and cultivate a work environment that creates opportunities to increase social support for clinicians. Now for today's presentation. We're really excited to have Dr. Laura K. Rock with us today as our presenter. Dr. Rock is a pulmonologist and critical care physician at the Beth Israel Deaconess Medical Center in Boston, Massachusetts, and assistant professor at Harvard Medical School. She has been leading programs to promote patient dignity, effective and empathetic communication, and team collaboration for over 10 years. She believes human connection is the path to a functioning team, patient safety, and what brings a sense of purpose and joy in our daily work. Dr. Rock encourages curiosity, transparency, humility, and the surprising power of a great debrief to encourage difficult conversations and promote learning. She conducts research on interprofessional team debriefing and patient safety and leads programs for a wide range of groups, including faculty, students, residents, and fellows related to effective and empathetic communication, including patient-centered critical care, trust, listening, feedback, debriefing, managing conflict at the bedside, toxic teams, and how to improve teamwork. She leads workshops and speaks worldwide on these topics. She is core faculty for the Center for Medical Simulation and a Vital Talk instructor. Dr. Rock was honored to be included in the Catherine Swan Ginsburg Humanism in Medicine inaugural faculty, the Putnam Scholar Award, awarded by the American Academy for Communications in Healthcare, and received additional communication training as an intensive talk faculty, Rapkin Fellow, Shore Family Fellow, Physician Leadership Program, and served as faculty director for the Gold Humanism Honor Society BIDMC resident chapter. Before I hand the mic to Dr. Rock, I'd like to go over a few housekeeping items. This webinar is being recorded, and the link to the recording will be sent to you all within 2 days. The PowerPoint slides can be found on the webinar registration page, which we previously linked to. This is a 2-hour webinar. The first hour will include a presentation on fostering social support. We'll have time for Q&A at the end of the presentation, so please type questions you have for the presenter in the chat box on the right side of your screen. You may have to manually open the chat box by selecting the chat icon in the bottom right corner. There will be opportunities to engage with Dr. Rock and other participants throughout the presentation using polling, the chat box, and by raising your hand to speak. If you have a technical assistance question, please contact our colleague Josh. His contact info is pasted in the chat. Polling will be used throughout this presentation using the Slido platform. You have 3 options for responding. The first option is to respond in the Slido box, which will pop up on the right side of your screen in your WebEx window. The second option is to take a picture of the QR code on the slide with your cell phone and enter a password, which will take you to the Slido website for this webinar. You can also manually navigate to the Slido website using the link, enter the numeric code, and then enter the passcode. Once you have navigated to the Slido website through the QR code or URL, please be sure to leave the Slido window open, as it will automatically update with the next question over the course of the presentation. Please enter each answer only using one of these methods. For the second hour of this webinar, we'll have time for a group discussion facilitated by Dr. Rock. Please stay on so that you can connect and share ideas with your fellow National Health Service Corps participants and Improve Site staff. Finally, we would appreciate your feedback on today's session. Please complete our survey at the end of the TA portion of this webinar and a separate survey at the end of the discussion to let us know how we did and let us know what could improve. To see closed captions, click on the CC icon in the bottom left corner of your webinar window. That is it for housekeeping, so I will hand the mic over to Dr. Rock now.
Hello, everyone. I'm really excited to lead this, hopefully, conversation, because I think that you'll get a lot more out of this talk if you can find ways to participate, either by kind of thinking to yourself and taking notes if you don't feel like using the chat or speaking up. But I have an agenda and some ideas and slides I want to share with you, but I mostly really want to get us into a conversation about how these ideas can be most useful to you. Sarah, should I just tell you when I want the next slide? I can't tell if I can change
Sorry,
the slide.
I was muted. I'm controlling the slides, so just say next slide when you're ready to advance.
Thank you. Next slide. Okay, great. So we're going to start with a poll just to get a sense of kind of where you are in your work and what kind of field you're in. So please answer this question if you have access to this technology. What is your role? We've heard from 2 people. Oh, here we go. Okay, so it seems like there's a bit of a mix, which is great. Maybe it'll bring some diversity into our conversation from your different insight. Next slide, please, Sarah. So I think we're missing a slide, the objective slide. Okay, we'll start here. So, okay, so from this session, I'm hoping you'll have a sense of what really is social support. What is the relationship of social support and resilience? And mostly, I really want to emphasize what you can do in your own role, either as a leader or as a very senior or very new clinician, to strengthen your social support networks. Next slide, please. I'm going to give you a moment to read this slide. Actually, Sarah, is there anyone who's just on audio and doesn't have access to the slides?
I believe all of our participants, I don't see any call-in participants, so everyone
Okay.
should have access.
So I'm just going to give you a minute to read this. So I take a bit of I take issue with the term resilience when we apply it to discussions about clinician wellness, joy, or burnout. And I think gratefully, I've noticed that there's a real shift in the literature and sort of in the general conversation about resilience, because I think until quite recently, there's been an overemphasis on personal resilience, which places a lot of burden on handling emotional distress solely on individual clinicians. And this is a problem because, I mean, first of all, this is just my opinion, but I don't think resilience is our problem. We've been through really hard education, medical school, residency. We've made a lot of sacrifices in our lives. We've done really hard work and we've been through a lot. And I would like to argue that resilience is not what we lack. I think what we sometimes lack is applying that personal resilience that we already have and finding ways to work within the systems that we have that can be very tragic and also very gratifying, and frustrating and also very rewarding, in order to kind of make the most of this resilience that we have. And so one of the things that I'm going to be emphasizing is the organizational approaches to improving clinician well-being, which is more effective than strategies to focus on personal resilience. And I don't just mean organizational approaches that require leadership to create programs for you, but what you can do at whatever level of training or work that you are in to find ways to increase social network inside and outside of work to improve your productivity, your joy, and your general experience. Next slide, please. Next slide, Sarah. Thank you. So social support is what it sounds like, a very broad term that just means there are a lot of different ways, many ways you can receive help through connections to others in your community, and that means in your work community and also in your outside of work community. Next slide, please. And there are many different ways of defining this or thinking about some of the benefits, which can be structural. So you can define it as looking at the size and reach or how often you're engaging with it. Functional, which is the perception of the value. Emotional, which I think is probably part of the definition of functional or structural benefits. So these are just different ways of thinking about the benefits of social support. Next slide, please. So, and the interplay between social support and resilience is depicted here. So the idea is that if you have effective social support, that will strengthen your resilience because it improves your ability to cope with stressful situations, alleviates some of the effects of emotional distress, promotes lifelong good mental health, enhances self-esteem. We know there's actually some really important physiologic data on lowering cardiovascular risks, among other things, and improving adherence to a treatment plan. And we also know this is true for patients, but we can apply these data to ourselves as well. Next slide, please. So you can be really creative when you think about different ideas for social support, which may be volunteering, joining a gym or some kind of fitness group, taking a class, even looking online. Next slide, please. And this more specifically may be if you are interested in advocating for a cause, joining a group like that. any kind of extracurricular groups and meetup events, which we'll talk more about later, and then individual connections such as friends, family, coworkers, neighbors, your community. Next slide, please. So I'd like to start this conversation with you by asking, who are your sources of social support outside of work? And then we'll get to the workplace in a later question. And as you're writing, I would like to emphasize that I really love interacting even during the talk. So if you have a comment, I'm happy to be interrupted and shift the conversation with a question in the chat, or if you want to raise your hand and ask a question.
Just for those of you who are interested in speaking and want to raise your hand, that's located towards the center right, the bottom bar of your webinar window.
I'm imagining, because if I ask myself this question, who are my sources of social support, I would probably have the same answers that you all do so far, which is family, spouse, friends. And you probably, I mean, if I really think about it, I have other sources of social support that are not as obvious. Like, for example, I'm not a big social media user, but I did started using Facebook a lot more in the last few years because of a group called the Physician Moms Group, which is a group of women physicians who chat about a whole variety of things, some of which are deeply personal. And of course, they're not anyone I know in real life, but it is a source of social support, I think, for a lot of people and other groups like that. Love it. Nature. Okay. Well, one more person is typing. Classmates. Great. Okay, let's go to the next slide. So now we're shifting to thinking about social support in the workplace. And there are a lot of ways of doing that. And before I talk about strategies, I'm going to ask you a question about your sources of social support in the workplace. But some that you can think of are working with teams. I think that it's rare that we have this tight a group hug like this photograph is implying, but you get the message. Informal and also formal peer support programs. I think a lot of hospitals do have them. And efforts at group engagement. Next slide, please. So what, if you can think about it, what are your sources of social support inside your workplace, if you have them? And it's okay if you say you don't, because hopefully by the end of this talk, you'll have some ideas about how to create them. My patients, I love it. Well, I love that it looks like a good number of you have a supervisor who is caring enough to play that role, and certainly our colleagues. Walking meetings, that's great. Okay. So I love this question, and I think that we may not realize when we're first signing on for a job whether the workplace is going to promote social support in the workplace. And I think it's something that if I were advising someone taking a job, I would want to know what kind of culture it is and whether people have each other's back. And also, even if you've been in a workplace for a while, how do you create an I have your back culture in a place that you're already working in? I mean, I think that most people want that. And if they haven't created already, you could be really a trigger for promoting that kind of culture. And we're going to talk about some ways to do that. Next slide, please. So one way that promoting social support and actually improving patient care is through understanding roles and expectations of team members. So here, I'm just going to read this for you. Role clarity mitigates duplication of effort and reduces stress related to uncertainty and ambiguity. Allows you to share and delegate responsibilities and recognize individual contributions, provide affirmation, celebrate success, and reflect and problem solve. So there's actually an entire sort of movement called relational coordination, which is led by Jody Hoffer-Gattel. She wrote the book on the success of Southwest Airlines, which I know lost a lot of its cachet last summer with all the air flying disasters. But be that as it may, they became a huge success. And her book, I forgot what it's called, but her book, which describes relational coordination in the airline industry, really led to a lot of research on this same question in healthcare. And what they found was that relational coordination improves patient care, has really robust improvement in clinical outcomes. And some of that is simply from understanding the roles of the people that you work with that you don't necessarily know, understand their roles well because you've never been in that profession. So I think, and the way to achieve that really is by perspective sharing. So actually asking your colleagues, especially on interprofessional teams, about their experience of managing a patient or what their tasks are in managing a patient, or when you're asking someone to do something for you or with you, asking if they're comfortable in that role and whether they enjoy that role and ways to support them in that role. And that can really change your social support for one another within your team. Next slide, please. And then another way of doing that, which is related, is thinking about how to be an informal peer supporter. So I mentioned that there are formal peer support programs, but becoming more comfortable with the process of going up to people, whether you know them well or even don't know them well, and ask them, what's something you're proud, like what, tell me about a genuinely exciting moment of something that happened today or something that went well. Or just saying, are you grabbing coffee? Do you want to chat? I think we could both benefit from a check-in. Or asking, especially after a particularly challenging encounter or experience with a patient, how are you feeling since that happened? And it may feel uncomfortable if you're not naturally that kind of very communicative or very social kind of person. But I think that it it takes a little bit of courage, and it also is sort of countercultural to how um, we've been trained and raised to work. So we've done a lot of we've done a lot of independent work, competed against one another for, I mean, not the people you work with now, but like you've been in competitive situations. And we haven't necessarily in our training or in our education been rewarded for teamwork and for supporting one another. And so it takes a little bit of a shift in our thinking to really shift towards a team mentality. And I think once you take on this role, it kind of changes your identity a bit. Like people will see you as someone who cares about them and someone who is a good person to turn to for some informal peer support. And I think, this may be harder for the more junior people. I feel like I got braver at doing this as I've gotten older, but I think it's sometimes worth taking that like today I'm going to be brave and, check in with someone I don't know, or, taking this, just challenging yourself to change your culture by being someone who does that, I think can really change the way you feel about your workplace as well. Next slide, please. So I want to take some time to share this acronym or this mnemonic called GIVE. So I think one reason why we don't check in with each other enough or even respond to is because people may feel like they don't have the skill set or the time or um, they may feel stressed about um, receiving a lot of emotion. So people may not know exactly how they're going to respond to emotion that's present, or may think they don't have the time to get into a big emotional conversation. And as Sarah said when she introduced me, I've been in critical care for 20 years, and I think that there's, when we have challenging conversations between patients and clinicians, or family members of patients and clinicians, it's often because we have failed to effectively respond to the emotion present in the conversation. And when emotions are intense, it's really hard to participate fully in a conversation. So even if you think you're doing shared decision making, if people are really emotional, they can't really share in the decision making because their headspace is just, their cognitive load is so overburdened by the emotion they're experiencing that they can't necessarily process what you're saying and make rational, helpful decisions that are in their own best interest. So I developed this mnemonic, and I have to caveat that I normally really hate mnemonics because I never remember what they stand for, but I really like mine because if you don't remember what it stands for and you just remember to give when you encounter intense emotion, that's probably enough. So the fact that you just recognize that emotion is present and you give over your agenda for even a few moments to that emotion and kind of drop what you're talking about, because in that moment, we need connection, not information. We need to be present and listen. If you do want to know what the steps of give are, they are pretty simple, which are get that emotion is present and pause. Identify what emotions may be present, or even the behaviors that may be suggesting that an emotion is present, which may be something like, I noticed you're looking down. I notice you're quieter than usual today. Sometimes it's quite obvious because they're screaming or crying. And you may identify it internally to yourself, but you may actually want to name it out loud if it seems appropriate. Validate by acknowledging what they're feeling. And this is not sort of normalized to kind of make it go away, but just validate, like, I can understand this must be really overwhelming. And explore to understand better what's driving the emotions. And that may be, I can hear you're scared. This is a really big surgery. I think I'd be scared too. Do you want to, what's scaring you the most? Or my favorite exploring phrase is simply, tell me more. So I think that the concept of give is really important in a variety of contexts. So it was really, I wrote it, and there's a reference in the references section that you're going to be getting in these slides. It's like a 2-page blog post in the BMJ called Don't Answer Feelings with Facts that explains the mnemonic and gives some examples of using it. So I'm going to give you 3 different examples. One is how it can be so powerful to use this concept of recognizing and responding to emotion with validation and exploring with a patient, and also with a colleague, and also for yourself. So one of my most kind of dramatic examples of this was I run a communication course for all interns rotating through the ICU every week. And I usually start the course by asking the group to tell me about the worst conversation they've had that week. And I do that because as I've grown as a teacher, I've realized that if I have this long agenda of what they're supposed to do to have a good conversation, but I don't address the bad conversation they had on their overnight shift, their thought bubble is going to be like, yeah, what you're saying is lovely, but it wouldn't have helped me last night in this really terrible meeting with my patient's sister. So I usually now start with their challenging conversations so that I can, because it almost always allows me to incorporate my teaching points anyway. So I asked them to describe their most challenging conversation they've had recently. And one of the residents said, yeah, I was in this really, really tough conversation with a patient's oldest son, the healthcare proxy. And the patient was in our ICU, 84-year-old woman who had very advanced anal cancer, which was so advanced that it was obstructing the stomach, and she was unable to eat or tolerate any enteral feeds. And she also had the tumor was eroding through her skin and actually exposed bone. She had been in and out of intensive care, and she was back in intensive care with sepsis. And the resident was having a code status conversation with the patient's healthcare proxy, her oldest son. She had 8 children, and this was the oldest child. And he said, well, can't you just put in the chart that she's full code but not do it? So, like, if her heart stops or she stops breathing, like, you'll say that you would put her on a breathing machine, but just don't do it. And I wonder if any of you might be brave enough to offer in the chat, what do you think this doctor said to the healthcare proxy? I'll give you a couple minutes to respond. So the question is, the resident said, can't you just write in the chart that she's full code but not do it? And I'm asking you, I'm sorry, the healthcare proxy said that, and what did the resident say in response? Or if you want, you could write, what would you say if someone asked you that? I'm not seeing any responses, and I'm not sure if it's just not a clear question. Would one of you please let me know if there's if I'm not making myself clear here?
I think you're clear, but if anyone wants to ask a clarifying question.
Okay, great. So Molly, thank you for being brave. Wrote, I would say I can't do that. Can you please explain maybe in another chat why can't you do that? Or someone else can add, why would you say I can't do that? Which is what this doctor said, by the way. Oh, I wish I were in a room with you all. Well, so this doctor said, I can't do that because it's not legal, exactly what Molly said. It's a legal document. We have to do what the chart says. We can't write one thing and do another. And then this resident also said, and it would be too confusing for the team if we wrote one thing and planned to do another. So the problem with that answer, which is totally correct, is that it's a perfect example of what I call answering feelings with facts, because it is an information seeking question, and the response is answering with information or answering feelings with facts. But when someone asks for something really pretty irrational, it's an emotion that's driving the question. So by using something like give and saying, that's a strange thing to request. I can imagine that's the identify. The validate may be, I can imagine this is probably the hardest thing you've ever had to do. And it must be really overwhelming. Explore. can you tell me how that might help you and your family, or your family and your mother, if we did that, if we wrote one thing and did another? And I'm not going to force you to chat the answers here because I'm not getting a lot of responses, so I will just speak. But you can imagine there, if you asked that and explored that way, you might hear a lot of reasons why they would ask, can't you just write in the chart and not do it? So, for example, maybe this healthcare proxy believes that they shouldn't do it, but there's a lot of fighting in the family and they don't want to be responsible for that decision. Or maybe they think they shouldn't do it, but the mom who he's healthcare proxy for said, whatever you do, keep me alive no matter what. Or, I mean, those are probably the primary reasons, but you can imagine that there's either inner conflict or conflict in the family or some confusion that by expressing, identifying the feeling, validating what they're going through and exploring, you can actually help them. So if they have conflict in the family, or if they feel obliged to uphold a promise to the mom, it would then, like, once you have the information, once you understand what's driving this emotion, then you can actually help them. So I think another way to think about give is simply, on a much more mundane level, like it's a sort of a style of listening. So we do a lot of task-oriented listening in our work, and sometimes that's very efficient and productive, but sometimes it really may miss an opportunity to understand better and support. So, for example, if you have a colleague who is distressed and basically says, "Oh, I just got our new schedule. I can't do all these weekend shifts," and you say, fine, I'll do your next shift. That's so nice. It's very generous. But if you are recognizing that there's an emotion present and saying, hey, sounds like this is hitting you hard. Yeah, sometimes the schedule can feel kind of rough. What's going on with you? You may you may actually uncover that there's something going on with your colleague that is bigger than simply taking a shift for them, although that's also lovely and probably would go a long way to helping them feel supported too. I just want to offer that you can use this kind of style of speech to support your response to emotion. And by the way, I don't mean to imply that you have to do each of these steps. Sometimes simply pausing is enough, or simply validating is enough, and you don't have to do every single thing. And even when you notice emotion in yourself, being able to say, wait a second, why am I having this reaction? I realize, like, my throat is tight and I'm having tachycardia, and I guess I'm feeling exhausted and overwhelmed. And to explore it, I mean, maybe I get this way because I really care and I feel, like I just can't, I don't have balance right now. So it may help you to unpack kind of what's going on with yourself emotionally and how you can start to address it. I want to ask if anyone has any questions or comments about this give concept, or if I should move on. Well, feel free to add them in the chat if you wanted to say something about that or ask a question. In the meantime, I'm going to move on. Next slide, please, Sarah. So all of these ideas, whether it's responding to emotion, an informal style of peer support, check-ins, are not a replacement for formal programs for mental health treatment. And even a formal peer support program is, I think, really effective for recognizing someone who may need more help than you have. But, I think it certainly doesn't replace the need for more kind of professional support. And it certainly isn't designed to fix every problem. But I think, one of the greatest tools for one of the greatest missions, I think, for informal peer support and all of our social networks is that in general, in our work, we tend to isolate ourselves when we feel either that we've done performed something poorly, or that we just feel a little bit broken. We tend to, either because of stigma, that we, are in a profession that doesn't really like enjoy expressing vulnerability, and that may even see vulnerability as a sign of weakness. I think I can tell you from my own personal experience, and certainly with some really wonderful colleagues who I respect tremendously and adore, that when we've made a mistake, it's very typical to isolate and kind of avoid connecting with others. And actually, the antidote to really burning out when we experience something like that is community, and it is connection. So finding ways to support ourselves and especially each other by offering this kind of informal peer support will really, in your entire career, will really help kind of strengthen your own, I don't know, your approach, your joy, your resilience. Even though I feel like that's become a little bit of a bad word because of this issue of putting too much burden on an individual. But I do think that by leaning on community and by creating community where it doesn't already exist, you can do a lot to help maintain your own joy and your own competence in work and that of your colleagues. Next slide, please. So other programs that exist that are just worth you knowing about, I'm going to just mention a couple of them. One is called the Schwartz Rounds. And this is a program, it's a national program, which if you are interested in doing this, is in the references as well. So Schwartz Rounds is a program that has been run by, I can't remember if it's the Schwartz, I can't remember their formal name, but they support efforts to create programs of doing Schwartz Rounds. And at least in our hospital at Beth Israel Deaconess Medical Center, Schwartz Rounds usually involves some clinician, doctor, nurse, social work, usually a doctor, selects a patient who had a particularly emotional impact on all of the different clinicians involved in their care. Maybe positive, often more traumatic, but often, I mean, I've seen many Schwartz Rounds that really took time to emphasize the sense of reward and purpose that a certain clinical experience brought. And it's really not so much like M&M or other typical kind of resident rounds where you spend a lot of time and effort to unpack the clinical aspects of a case. But Schwartz Rounds is really about unpacking the emotional and social aspects of a case, and often have speakers, including the social workers involved, the chaplains involved, any clinicians who were involved in their care. And it's just an opportunity to reflect together on the experience. And there's a lot of audience participation, usually. So that's one option. And if you wanted to bring that, oh, thank you, Sarah, for putting that in the chat, Schwartz Center. There's a link in the chat to doing that. So anyway, I've been involved in Schwartz Rounds. I'm not one of the leaders of it, but I've been to several Schwartz Rounds as either a participant, a speaker, or just in the audience. And I do think it's a really wonderful way to connect with the emotional and social aspects of a case. Next slide, please. So Team Steps is a very well-known program that actually I think started looking at crisis resource management training, and now has a really robust set of programs on teamwork. And so they emphasize these four things: leadership, situation monitoring, mutual support, and communication. And so if you go on their website, you can find different tools. And I actually went on their website before this talk just so I could be a little bit better prepared to talk to you about it. And if you go on their website and you type in the word team in their little search box, you get a whole bunch of options. And one of them is a team performance observation tool. So you can use this to just have a little bit more expertise on to bring to your own teams about ways to improve your team's performance. So for example, under leadership, it has identifies team goals and vision, uses resource efficiently, balances workload, delegates appropriately, conducts briefs, huddles, and debriefs, and role models teamwork behaviors. And each of those topics, situational monitoring, situational awareness, mutual support, and communication. I think it would just help you feel a little more expertise if you are bringing this kind of tool to your own team. And I'm going to talk about one way you might do that on the next slide, where I share a debriefing program that I led. Next slide, please. So I wrote this paper called Circle Up that is in the New England Journal of Medicine Catalyst Journal, which is an online journal that specifically focuses on healthcare innovations. And the idea is a program for doing briefings at the start of a shift and debriefings at the end of the shift with some peer check-ins throughout the day. And the purpose of this is to really promote peer check-ins, to promote team connection, and it's really meant for both workflow efficiency and kind of the social support piece or relationship building piece. And one way to do this that I honestly think we should be debriefing everything. So like after this talk, I should debrief with Sarah and the others who invited me to speak and say, how did it go? What should we do differently next time? It could be 5 minutes, but I think that the fact that in healthcare that we don't generally take 5 minutes at the end of a clinic or the end of our critical care shift to just check in, like how was today? Could it be 1% better? And it's just mind-blowing to me that we don't learn from our work by these brief debriefings. And my goal for the summer is to finish writing a project that I did, which was in one of our ICUs, where we did a debriefing every day at 4:00 with everyone who was in the unit. So, and then we chose 4:00 because the nursing shift ended at 7, but the physician turnover was at 5. So we didn't want it to really interfere with people's charting or any kind of end of day responsibilities. So at 4:00 every day, the entire team, including all the doctors, all the nurses, respiratory, the unit secretary, the PCTs, which is also called medical assistants in different places, the housekeeping, if they were present and available, transport, whoever was around could join this conversation. And it was really the first time that teams were asked not to talk about patients, but to talk about themselves and their day. And how was the day for you? How could we have supported each other better? Why did it take 25 minutes to give this patient, 23% saline who was having a acute intracranial pressure elevation? So, what's really, to me, the idea of debriefing at the end of a shift, I'm very biased. This is my main passion now. It really incorporates a lot of what we've already talked about. So, we know from research on physician wellness that physicians want to talk to their colleagues. They do not tend to use wellness programs or mental health programs that are offered to them. And one of the main barriers for seeking help is time. So I think, when we incorporate into our actual workday, then we've removed the issue of that barrier, which is time. And we also know that physicians and nurses want to speak to other people who have gone through what they've been through. And in one study on this subject that was in JAMA actually this was Archives of Surgery in 2012, showed that physician colleagues were by far the highest potential source of support for people who were seeking anyone to talk to, much more than employee assistance programs or mental health professionals. So, I think that by knowing that already and knowing that time is a huge barrier, and also, the stigma that people may feel about seeking help, if it's built into your workday, then there's this opportunity to not only talk about challenges or efficiency problems or workflow issues, but it builds relationships. It allows us to get a sense of whether someone may be struggling and need more formal mental health or peer support. So I think this is something that's really easy to do, and I'm happy to help you if that's something you're interested in doing, or you could start by reading this short paper and get some ideas. And I think it incorporates some of these other ideas that I've been talking about for promoting social networking within your own institution, within your own clinic. Next slide, please, Sarah. And then connecting with peers in your field is, some of this may seem obvious. Certainly affinity groups, creating, one thing when we were working so much during the pandemic, my critical care group, there's about 30 of us, created a WhatsApp group. And our WhatsApp group is used for, everything from I can't, I can't take another admission right now, like just venting to, does anyone remember the indications and contraindications for, angiotensin 2, or, so we use it for help. We use it for, can someone dog sit my dog this weekend? We use it, mostly I think it's mostly clinical and kind of emotional. It's 30 people, so it's not like really intimate, but it's been a nice way to connect, especially during the pandemic when we weren't seeing each other except when we were on the same shift. And then a lot of people have great success connecting in professional organizations and creating sort of a professional home. I have been very involved in simulation work, so my professional home was really through that for many years, even more than in my own clinical situation. And then, of course, informal gatherings. So there's a group of women in my division that, like, some of the more senior women that, like, I would say every 4 or 5 months, we make an effort to have dinner together, which is really hard because everyone has their responsibilities, but we, make it work. And it just takes a little initiative. Like, I think just making an effort to be the one to get the ball rolling and starting to schedule that, it just makes an enormous difference in how you feel about your colleagues and your work. Next slide, please. And then, of course, maintaining your connections outside of the workplace, it can take effort. It's, everything, relationships take effort. If you don't put effort into relationships, you lose them. I've met people who made amazing connections through meetup.com. I haven't tried it myself, but I just met some really cool women recently, and I asked them how they met, and they said they were all they met in a meetup, and I was like, wow, that's so cool. And that's how they met, but now they're, legit friends and, aren't necessarily part of that meetup anymore, but that's how they met. And then I think now we are going to, we have a case study, and then we're going to get into actually understanding a bit more about how you might use some of these ideas and how you already are building your own connections. So let's go to the next slide, please. So here's a case. I'm going to read it, even though you can read it too, just so we're all on the same page. After working for multiple years at an urban site, Dr. C transitioned to a site in rural Texas and struggled to replace. Oh, the chat. Oh, it's not working. That is really good to know. And I would also really welcome, even if we want to do this before we move on to the case study, if you want to if Sarah, if you can help with unmuting so we can actually hear from people, I would love that. Because I'm not used to doing these unidirectional talks. Oh, it's working now.
Oh, working now.
Okay.
Thanks, everyone.
Thank you. Okay. So, all right. So this doctor had worked in an urban place, moved to a rural place, and then really struggled with that, lacked connections and supportive peers. And just to give a little more background, let's say this is Dr. Dr. C. So she worked in an urban clinic where she felt very connected, maybe even had some of people she trained with in her area. And then she moved because there was a family member who needed some in-person support. So she moved to help them. And then in addition to feeling the added stress and, of course, feeling the sense of reward from helping this person, also felt stressed by caring for this family member while also working, and then missed the connections and support that she had in the past. And she really didn't have a peer network in this rural town, and, was kind of more and more aware of the constant reminders of the high rates of burnout among doctors, and aware of the numbers of people leaving the profession and feeling just very burdened. Next slide, please. And so the question, oh, sorry, go back to the last slide. So I guess the question I want to raise is, like, based on some of what I've talked about and your own ideas, what would you propose? How do you think, actually, maybe this is the next slide. I'm looking at a, oh, maybe I jumped the gun on this. Oh, here we go. That's what I was looking for. So, if you had a friend who was in this situation, or you were colleagues with this person, what do you think you would advise? I'm a little bit iffy on our ability to interact here. So I guess I'll.
I'm happy to chime in on that. So I believe the chat should be working now, so you can go ahead and respond there. But also, if you would like to respond aloud, you can go ahead and click the raise hand icon. It can be found in the bar at the bottom of your screen towards the center right. If selected, you'll receive a request to unmute. You can then unmute yourself by selecting the microphone icon at the bottom left of your screen, or the unmute in the message that pops up. And please wait to mute yourself again until your response has been fully spoken and responded to, because once you go back on mute, we have to repeat the whole process. But yes, please just go ahead and raise your hand if you at all interested in speaking.
So maybe until I see some responses, and Sarah, please interrupt me if anyone does make an effort to join. I think this is a really tough case, because this doctor, and you might say, well, this isn't working, move back to the city. But obviously this doctor had a reason to move there in the first place. And, maybe there are some ways that she can continue to support this family member who isn't mobile, and not be sort of preoccupied with these feelings of burnout and feeling more connected. So I think, it may, some factors, I mean, we don't know specifically about her time burdens, but it could be that it was harder for her. I mean, in a rural area, it's probably harder to connect with people anyways. There aren't as many people, but also maybe didn't have the time because she's busy helping this family member when she's not working. So Mari is offering virtual support groups online. So that's great. I'm wondering, I don't know if you have any examples, but I think, connecting even in these, even if she left the urban clinic, maybe she could stay connected with some of the people that she felt really supported with there, even when she's physically not there. I think connecting with a professional organization where she could feel like she's part of a bigger group could be really valuable. And, I So there's a program called Project Echo. Do we have a slide about this? I think we do. This is which stands for Extension for Community Healthcare Outcomes, which is very good segue from Mari's comment about virtual support groups. So this is a virtual peer networking and learning model that brings clinicians together to develop their ongoing medical education and navigate care management challenges. So through Project Echo, she was able to find a community of like-minded professionals, other healthcare workers who were working towards that same mission. And then she could kind of rev up her energy and her passion for the work while still staying in this location and able to support her family member. Have any of you tried Project Echo? I'm curious. I actually hadn't heard of it before. Catherine Ryan says, I like the idea of suggesting peer professional groups that are specific to rural as well to help her to adjust. Yeah, because I think a lot of people really love rural healthcare and TB. So is there an echo group that's specific for tuberculosis? Is that what I'm reading for that? I'm a pulmonologist, so of course I think TB is tuberculosis. I don't know. There's another acronym there. So that's a really great resource to know about. And I think, even if you go to a conference and you like have a great connection, even if it's brief with a couple people, maybe you could say, hey, I would love to stay in touch and create even your own organic support group through having an in-person meeting too, even if it's only a brief one-time thing. So I say be brave, try it. And thank you for that link, Molly. So we're going to move on. Really terrific. I'm curious if any of you who have participated with Echo want to say anything about it. We can go to the next slide while we're waiting for anyone to chime in about that. And the next slide. So maybe we'll move on to the references slide while I ask for questions and comments. So here are the references that refer to what I talked about. Beth Cumberland shared, it's a great experience to share case studies and brainstorm options for care. Great. So that's, I think, sounds like a great resource. Okay. And you'll have access to these through when you get the slides later.
Yes, the slides are currently posted on our webinar registration page, so you can feel free to download those as well as the related materials created as part of Series 2.
Great.
We would love to use some time now to answer any questions that the audience might have. So if you feel so emboldened, please feel free to raise your hand to ask Dr. Rocht a specific question, or you can paste them in the chat. Now, one thing that came to mind for me while I was listening to this talk was how do clinicians balance the idea of kind of their own time while still being that supportive person for their colleagues? Is that something that you've ever struggled with?
Yeah, I think that's a huge struggle for every caring and passionate professional. That's a great topic, Sarah. I think balance is really tricky, and at the end of the day, you can't do everything perfectly. So recognizing when you need to kind of shift, sometimes you're gonna maybe not emphasize or not put as much time and effort into aspects of your life that need it, like relationships when you're working really, really hard for a while, and then so important to recognize that imbalance and come back to it. Sometimes I think even like giving yourself reminders in your calendar, because sometimes uh, I may forget if I'm, if I like even connecting with certain friends, I literally have to give myself calendar reminders because too much time can go by when I get too busy with other things and don't commit to that. And it does take effort. So I think, and I have teenage kids now, and so they have different needs for me than when they were younger. But there were times when I really had to do less academic work and have more family obligations, and other times when I've really, you know, not been present as much as I wanted to for my work, and it's a constant toggling.
Thanks, Dr. Rock. We're still accepting questions, but we have also opened up the evaluation poll just so to get some feedback on this first hour of the presentation. Please stay on after completing it because we still have some time for our group discussion. Another question that came up was about the experience of implementing Circle Up and getting that started. Were there
I'd love to
any,
talk about that.
yeah, challenges that you faced?
Yeah, I don't know why I can't see the questions, but anyway, so I think that the way the Circle Up program is described in the paper is a little bit maybe daunting. And the way I would recommend starting it, and I don't know if the person who asked this question does outpatient clinic or inpatient, has an inpatient role, and please feel free to let me know, but I'll speak to maybe both. And so I think, if you have an inpatient unit, I think starting with maybe just the debriefings and letting everyone know in advance, I want to start this thing where we just check in about how the day went. So at 4 o'clock, we're going to meet for 5 minutes, or we said 10 minutes, and we always tried to limit it to 10 minutes because I didn't want people to feel like they were getting pulled into a really long conversation that they were afraid that they wouldn't be able to extricate themselves from. And sometimes it was 2 minutes. Like if they felt like it was an easy day or it was a smooth day and they didn't have much to talk about, we didn't force them to talk. So and I mean, the way I did my program was I actually worked with two social workers and trained them to be the debriefers. So I wasn't running it, and we didn't have anyone on the team running it. But if you have no funding and no people to support you, you could certainly do it yourself. But what I had them do was just at 4 o'clock, we'd all gather and say, the social worker would say, sometimes it would be like, how was Tuesday? Or what's what's on your mind? Reactions to today? Or they might say, how could today have been 1% better for you or for your patients? And just let them talk. And they really, the nurses loved it, especially, but even the very skeptical and kind of cynical docs, after a while, really felt like it just made the communication throughout the whole day different and easier because they were connecting in a way that they had never connected before. And, I think if I actually really implemented it during COVID. The morning huddle was really valuable to me because I was in the ICU, often with people I've never met before, often with clinicians that weren't used to the ICU. And one thing that's really powerful for it is it's a really important and easy way for leadership to communicate to the people on the front lines in a morning huddle, and it's a really effective way for the front lines to communicate with leadership, especially in the debrief. So in the morning, our whole team would gather, and literally the whole team. Like I literally included housekeeping because they're always so important in our ICUs. But it also just sends a message like everyone here is part of our team, everyone is important, everyone is valued. And so in the morning, we would just introduce ourselves, and sometimes people would say if there was something that was like really affecting them. Like I might say, if I'm a little distracted today, one of my kids is home and sick, so I may be like answering my phone more than usual. Um, and it it sets a tone for the day. Like I think we sort of were able to connect and promote sort of a team unity and a like just a kind of different tone. And people would like comment on each other's scrub caps or, you know, and we usually also created a WhatsApp group for the team for that day to make it easier to communicate on the shift that day. And it's really quick. And it was a way to connect personally and also say if there were any changes to the PPE or the protocols that were happening during COVID, or any major movements with patients. And then the whole thing was less than 10 minutes. And then we also do a morning huddle that's standard in our ICUs about our patients. But this was really, as I said, these, what I'm talking about is huddles and debriefings that are about the team and about the people on the team. And then the afternoon is really a debrief of the day. So the morning huddle is kind of a setting a tone and kind of a team approach for the day. And the afternoon or evening is really about debriefing the day. And I really think outpatient, it could be exactly the same. Obviously, the topics might be different, but you might take 5 minutes at the end of clinic and say, hey, how did clinic run? Did everyone feel supported? Can we talk about why we were running 25 minutes late? What happened with that patient that got roomed that we didn't actually know about? Or, you know, whatever it is. It's an opportunity to talk. And usually we have ideas and we have a lot to talk about. We don't have a forum to do it. So doing that, creating this opportunity, just really changes the possibilities in terms of communicating among the team and even communicating between leadership and the front lines. And if this is something you really want to implement, if you want to collaborate with me, I've never done this outpatient, I'd be curious. Yeah, I think that's, you know, I think doing it on a really small scale is, you know, probably best first, and then you know, you can broaden it as you feel success.
Thanks so much, Dr. Rock. We're going to wrap up the technical assistance portion of this webinar, but for the next hour, we'll be engaging in a group discussion around the topic of social support.